Hi everyone. So today we are going to discuss an important topic in ophthalmology and optometry, the bacterial corneal ulcer. So here we will discuss about the risk factors and the pathogenesis of the bacterial corneal ulcer. So let's get started. A corneal ulcer occurs when there is a break in the normal epithelial surface of the cornea, which is outermost layer of the eye. This break is often associated with necrosis. One of the most common cause of corneal ulcer is infective keratitis. This condition refers to an infection of the cornea that can lead to an ulcer if not properly managed. In this slide, we are focusing on bacterial corneal ulcers, which are a serious form of infective keratitis. There are several factors that can contribute to the development of the infective corneal ulcer, such as compromised local ocular defense. So the cornea has its own defense mechanisms such as tear films and intact epithelium. If these defense mechanisms are weakened, for example, due to an injury and contact lenses misuses or dry eye, the cornea becomes more open to infections. The another factor is compromised immunity. So if a person immunity system is weak, whether due to systemic conditions like diabetes or the use of immunosuppressive medicines, their ability to fight off infection is reduced, and that will increase the risk of corneal ulcer. The third reason is the virulent organisms. So there are some bacteria are particularly dangerous and can cause severe damage to the cornea even in people with the normal immune functions. These organisms can rapidly progress to cause an ulcer if not treated properly. Now coming to the etiology. So etiology basically refers to the cause or set of cause behind a particular conditions. So in this slide we are discussing the primary factors that lead to the development of purulent corneal ulcers. So basically there are two main factors involved in production of purulent corneal ulcers. So the first one is the damage to the corneal epithelium and the infections of the eroded area. So interestingly, there are certain pathogens that can invade even an intact corneal epithelium and cause ulcerations. These includes Neisseria gonorrhea, Corynebacterium diphtheria, and Neisseria meningitis. These bacteria are particularly aggressive and can breach the normal defense of the cornea. Now let's delve into a various type of corneal epithelial damage that can predispose the cornea to infection. The first one is the corneal abrasion. So this basically refers to the scratch or injury to the corneal surface which can be caused by the foreign body like dust or sand or misdirected eyelashes. The another factor is the xerosis and the exposure keratitis. So xerosis basically refers to the drying of the corneal surface often due to inadequate tear productions, while exposure keratitis occurs when the eyelid do not close properly, leaving the cornea exposed and prone to the damage. The necrosis of the epithelium basically seen in the conditions like keratomalacia, where the cornea begins to soften and break down due to the vitamin deficiency. The bullous keratopathy is the conditions involves the formation of blister on the corneal surface which can lead to the epithelium breakdown. The last one is the epithelial damage due to the trophic changes. This basically refers to the changes in the nutrition or support of the corneal epithelium which can result from the nerve damage or other underlying issues. So this slide basically covers the different sources of infections that can lead to the corneal ulcer or keratitis. So the first one is the exogenous infections, is basically originate from the outside of the body, and there are several potential sources like conjunctival sac, lacrimal sac, infected foreign bodies, infected vegetative materials, and waterborne or airborne infection. In addition to external sources, the infections can spread from the adjacent ocular tissues also. The another source of infection is the endogenous infections, which basically comes from within the body. These are very rare in the cornea because the cornea is avascular. It means it does not have a blood vessels that could carry the infections from the other part of the body. There are some causative organisms also which basically causes the corneal ulcers. Those are gram-positive cocci, gram-positive bacilli, and gram-negative cocci and gram-negative bacilli. Now coming to the pathogenesis of the localized corneal ulcer. So a localized corneal ulcer basically progresses through four main stages. In the first stage, that is progressive infiltration. In this first stage, we see the infiltration of the immune cells including lymphocytes and polymorphonuclear cells into the corneal epithelium. This basically occurs in response to an infection. These immune cells contribute to tissue necrosis, which is initial step in the ulcer formation. Essentially, the cornea start to deteriorate as the body attempt to fight off the infection. Second stage is the active ulcerations. This basically results from the necrosis and the slugging of the epithelium, Bowman's membrane, and anterior stroma. During this stage of active ulcerations, there will be circumciliary congestions, which results into accumulations of purulent exudative on the cornea. There also occurs a vascular congestion of the iris and the ciliary body and some degree of iritis due to absorption of toxins from the ulcers. Exudations into the anterior chamber from the vessels of the iris and the ciliary body may lead to formation of hypopyon. And if the ulcer is not treated promptly, it can progress further. The ulcer may reaches to the descent membrane, and that potentially leading to the desmetocele and even corneal perforations, which is a severe complications of the corneal ulcer. And if it spreads laterally across the cornea, that will cause more widespread superficial damages. Third stage is the regression stage. So in this stage, the body defense mechanisms come into play. A line of demarcation develops around the corneal ulcer consisting of leukocytes that helps to neutralize the corneal infection. And also along with that, the superficial vascularization occurs as the ulcer is started to heal and the epithelial begins to grow over the edges of the corneal ulcer. And finally, in the cicatrizing stage, the healing process continues with the epithelializations and the formation of permanent covering. Fibrous tissue is laid down, leading to a scar and the opacity formation. The degree of scarring basically depends on the extent of the damage, and if the damage is superficial, the ulcer heals without any significant scarring. However, if the Bowman's membrane and some superficial stroma are affected, a nebular scar forms, which is relatively less severe. And if the ulcer involves up to 1/3 or more of the anterior stroma, then the scar can be more pronounced and leading to macular and ligamentous scar, which basically impact significantly vision. Now let's delve into the severe complication of the corneal ulcers, that is corneal perforation. This basically occurs when an ulcer deepens and eventually reaches to the descent membrane, and that will lead to the significant complications. So as we know that when the corneal ulcer progresses to the stage where it reaches to the descent membrane, it forms a desmetocele. This is a situation where the ulcer has eroded down to the deeper layer of the cornea. At this point, the structural integrity of the cornea is severely compromised, and there are various actions or forces exerted by the patient, such as coughing, sneezing, or straining during the bowel movement can exacerbate the conditions and lead to the formation of the corneal ulcer. This is due to the increase in the intraocular pressures or physical stress placed on the weakened corneal tissues. In cases of perforated corneal ulcers, the intraocular pressure is often low. This is because the formation leads to a loss of aqueous humor, which can reduce the pressure inside the eye. Next, we will explore a severe complication of the corneal ulcers, that is slugging corneal ulcer leading to the formation of anterior stromyloma. This basically occurs when a highly virulent infecting agent causes extensive damage to the cornea and surrounding structure. In cases where the infecting agent is particularly virulent, it can lead to the total slugging of the cornea. These extreme damage result in the exposure and prolapse of the iris. The corneal tissues deteriorates completely, leading to a severe loss of the corneal structures. During this process, the iris becomes inflamed and there is an accumulation of exudate. The inflammations can also cause the pupil to become blocked, further complicating the conditions. The presence of exudate contributes to the overall damage and leads to the significant discomfort and vision impairments. As the exudate organizes, it forms a fibrous layer over the exposed iris and anterior chamber. This fibrous layer, along with the regrowth of the corneal epithelial cells over it, forms what is known as a pseudocornea. This structure is not as functional as healthy cornea, contributes to increase the intraocular pressures. The increased IOP and the formation of pseudocornea lead to bulging of the anterior segment of the eye, resulting in an anterior staphyloma. This condition is characterized by an outward bulging in the eye anterior portion due to the pressures and the fibrous tissue growth.